So let me start. Most of this presentation will be on early infarction. So I want to place some emphasis initially on the findings on CT. I like to refer to this first sign as the loss of the gray-white interface. And basically, it refers to a whole class of entities in which the gray matter decreases in CT density and becomes isodense with white matter. So there is a common sign in which we see this feature, and that's called the loss of the insular ribbon sign. I'll show you many examples of that. Another gray matter structure that can lose CT density and be a manifestation of early infarction is the basal ganglia losing density and becoming isodense with adjacent white matter. There's another finding. It's called the dense middle cerebral artery sign, but in fact it can be seen in any artery that thromboses, so it's not isolated to the middle cerebral artery. And then finally, and this is a relatively late finding, is mass effect, and that typically is seen as diminution of the sulci, or if the infarct is adjacent to the Sylvian fissure, narrowing of the Sylvian fissure. So let's look at some examples here. Here is, I believe, a relatively obvious example of the insular ribbon sign. I've got arrows on it. So let's look at the normal side. Why is this called loss of the insular ribbon? What is the insular ribbon? Well, the insula is a gray matter structure as outlined here. Normally there is a strip of white matter subjacent to it. So individuals have likened this to a ribbon of gray matter against a background of white matter. When the insula undergoes infarction, the gray matter loses CT density and becomes isodense with adjacent white matter. And that's exactly what we have here in the patient's left hemisphere. You can see that the insula and the subjacent white matter now blend together. Here is a relatively subtle example, and if you're looking carefully here, you can see that I've really narrowed the windows to make the infarct obvious. I believe this is relatively subtle, but still the finding is there. This is the insula right here. It should look like a strip of bright gray matter against a background of white matter, but it does not. And here is an example of a hypodense lentiform nucleus. Again, the principle being that a gray matter structure should be bright against the background of white matter. Now, I think this is about the most subtle one I've seen, and that's why I'm giving you a few seconds to look and see if you can determine which side has the infarct. If you look closely, so what are we looking for here? We're looking for the lentiform nucleus to be a triangular structure with its peak pointed medially, and it should be bounded by a low density area that's a relatively narrow dark line. On this side, the gray matter in the lentiform nucleus is a little bit darker than in the opposite side, but the posterior limb of internal capsule here, which is represented on the normal side here, the posterior limb of internal capsule on the affected side is much thicker. And that's because the adjacent lentiform nucleus has lost some of its density. I could walk past this very easily, I assure you, and not pick it up. So if it seems relatively obscure to you, don't be surprised, because I also find it that way. But looking at it 2 days later, when it's a little too late to treat the patient generally, it becomes very obvious. So you can see here a rounded area of low density just in this area where the posterior limb of internal capsule looked too thick, confirming that this was an early infarct. Now, a number of articles emphasize that often one can find an early infarct if CTA has been performed. Often one can find it on the source images from the CTA. And here is, I think, a very obvious example. So we should see the white matter here going out scalloped fashion out to the cortex. But here, the cortex has become low density and is now merging visibly with the subjacent white matter. So that's a very obvious case. I actually find it hard to pick this out in most CTA source images, but nonetheless, on occasion, you can do it. And here is the counterpart. This is, which is occlusion of the middle cerebral artery here, and you can see that there is some flow proceeding distally. Now, in my experience, talking about occlusion of arteries, usually by the time a CTA has been performed, usually hours after the time of infarct, there's commonly some reperfusion, distal flow in the affected artery, either from collateral flow from the external carotid arteries or from lysis of the thrombus and anterior or anterograde flow. So there is, in my experience, not a tight correlation between the presence of an infarct and an occlusion. The way I look at it is many of these occlusions are due to embolic events, and emboli frequently are lysed spontaneously within the first few hours. So to take an extreme case, if you saw an infarct like this and a patent middle cerebral artery, it should not mean that there was not a previous occlusion. It should not mean that this is, in fact, a diseased artery. Often there will be anterograde flow by the time we do imaging. So here are some more examples, and whenever possible, I've given you the time interval between the onset of symptom onset and the time of imaging. So here is a very obvious hyperdense middle cerebral artery. And here's the same patient 14 hours after the initial imaging, and you can see here that a large amount of the adjacent white matter, including the insula, is now hypodense and therefore isodense with white matter. I want to point out a subtle finding that I pay a lot of attention to with pretty good success. So the middle cerebral artery distal branches here can appear slightly bright or very bright. Now here's a very subtle example of slight hyperdensity within a branch in the middle cerebral artery. And that is likely due to either very slow flow or more commonly pieces of an embolus breaking off and lodging downstream in branches in the middle cerebral artery. Now I have some more examples. I have a lot of examples of that here. So let's look at this case. Here is a patient with loss of the insular ribbon on the right compared to the left side. Here, the patient also had a hyperdense middle cerebral artery on a cut that was more caudad than the initial slice. But if you look carefully, you'll see that there are these two very bright dots. And this has been called the MCA dot sign. And it's very helpful because on occasion, the only finding of a hyperdense artery is the presence of these little dots of MCA branches within the sylvian fissure. And they become very obvious because the background is CSF, so it's very dark. So the signal-to-noise ratio or signal-to-background ratio is very high. Here's another example of a hyperdense artery. Now, I saw this case, actually, this is a case that was missed last week. So if you look at the if I could have removed this arrow, you'd see that the adjacent insula doesn't look particularly abnormal, but we do have this hyperdense artery. So I've re-windowed it and moved the arrow off, and you can see that at very narrow windows, at 40-40 or 30-30, the insula does appear dark, so it's abnormal, and it's right next to the middle cerebral artery hyperdense artery sign. And at a higher cut, again with these narrow windows, you can see that the insula really is very conspicuously altered in CT density. So, as with anything in life, often we have to put together 2 or 3 things to make sure that we are correct in our diagnosis. So the finding of a hyperdense artery is an indication to me to look carefully for evidence of low density within structures that would be supplied by that artery, or vice versa, the finding of low density in a CT structure, a structure on CT, is an indication to me to look carefully for a hyperdense artery. All right. Here's an example of sulcal effacement. Now, it's not very evident, but it is present here on one side, and it's very early on. It's at 3 hours. So let's have a show of hands. How many people believe that the sulcal effacement is on the patient's left side? Okay. How many on the right? No one? Okay. Very good. So there, in fact, we do have normal sulci here on the right, but not on the left. Now, I'm showing you an example here at 3 hours, but in my experience, it's very unusual to see this finding within the first 6 to 12 hours. And I've reviewed the literature extensively on this, and most authors have indicated that sulcal effacement was rarely seen, only in about 10% of cases, before 12 hours. So this is an unusual case. But nonetheless, here's this patient at 26 hours, and you can see not only the sulcal effacement, the narrowing of the Sylvian fissure, but there's a large infarct, including involvement of the insula. So if I saw this finding, I would be looking carefully for a hyperdense artery in the middle cerebral artery, because this is the middle cerebral artery territory. Okay, so this is a culmination of what I found from reviewing, I think, about 40 articles on the CT findings in stroke dating back to the late 80s. And basically, the hyperdense artery, the insular ribbon sign, and the lentiform nucleus sign were commonly reported by various authors within the first 2 hours. But sulcal effacement was only reported in 5 to 10%, or 0 to 10%. Some articles it was 0%. Now, as you go out in time, these numbers remain high and become higher, but the sulcal effacement starts to be seen, and particularly after the first 12 hours. So if you were asked by a referring clinician, take a look at this case, how old do you think this infarct is? You could use these findings to more or less make a judgment that at least is educated. Basically, if I see the first 3 signs but not the 4th, I tend to think that it's an infarct that's very recent, and typically less than 12 hours, often less than 6 hours. That's not an everyday phenomenon, but actually I get asked a lot about how old I think the infarct is, because it has an impact on whether TPA will be administered. Okay, so you may come across this somewhere in your reading later today, perhaps. All right, so here's an example. Now, this is a confounder. Patients who receive tissue plasminogen activator to so-called bust a clot. After TPA is administered, if it's given intraarterially, there is a lot of contrast material on board. So it's not uncommon for me to see something like this, where it looks like a hemorrhage has developed within the infarct. But that's a confounder. It's not usually due to hemorrhage. It's due to the fact that this infarction is characterized by loss of normal endothelial function and also loss of autoregulation within the arteries in the infarcted territory. And as a result, the arteries may dilate and actually start to leak. So this is actually leakage of contrast material into the infarct very early on. It's not, it doesn't represent hemorrhage. And I know this from experience, from having seen a number of these cases over the next 24 hours start to lose the high density, which indicates that it's not hemorrhage, but instead now the contrast material is being washed out. So be aware that that can occur after TPA is administered.